Good evening, everyone. Welcome to our first international panel discussion on the therapeutic utility of HRD in ovarian cancer. We are delighted to have our eminent and elite group of experts with us today from India, Nepal, UAE, and Uzbekistan. I would like to start by introducing our esteemed moderator, Dr. Vamshi Krishna M. Dr. Vamshi is the Director of Department of Medical Oncology at AIG Hospitals in Hyderabad, India. Along with Dr. Vamshi, we have 6 panelists. I would like to start the introduction of our panelists in alphabetical order. Today, we have Dr. Abdul Rahman with us. Dr. Abdul is the Head of Department and Consultant in Medical Oncology, Hematology at Fakia University Hospital, Dubai. And he's also an Assistant Professor at the University of Sharjah, UAE. Next, we have Dr. Akhil Kapoor with us, who's an Associate Professor in the Department of Medical Oncology at Homi Bhabha Cancer Hospital and Mahamana Hospital, Tata Memorial Hospital, Varanasi, India. Then we have Dr. Maksud Mallayev with us, who is the Head of Department of Medical Oncology at CityMed Hospital. And Dr. Maksud is also a professor at Tashkent Medical Academy, Uzbekistan. Joining us on the panel is Dr. M.V. Chandrakanth. Dr. Chandrakanth is consultant in medical oncology at NH Group of Hospitals and Rabindranath Tagore Institute of Cardiac Sciences, Kolkata, India. Then we have Dr. Shona with us. Dr. Shona is the Director of Oncology Department and Senior Medical Oncologist at Sahyadri Hospitals, Pune, India. We are also honored to have Dr. Sudip Shrestha with us today. Dr. Sudip is the founder and chairman and senior consultant in medical oncology at Nepal Cancer Hospital and Research Center, Kathmandu, Nepal. So I'll quickly brief the agenda before I hand over the session to Dr. Vamshi. Dr. Vamshi will start with a small brief presentation on the therapeutic utility of HRD in ovarian cancer, followed by the case-based panel discussion. So I request the audience to keep on putting the questions in the chatbot window. We will address all the questions by end of the session. Now I will request and hand over the session to Dr. Vamshi Krishna. Sir.
Good evening, everyone, and thanks to the team from Strand for having me here. It's nice to have a discussion, and it's truly interesting that we're having so many people from different countries to discuss this interesting topic. So what I will be doing is I'm not going to give too much of a, okay, can somebody... Okay, I hope yeah. So I would not spend too much time in a didactic lecture. These are things which a lot of us have been talking about in the past 3-4 years. I'll just give a brief overview about HRD and about the somatic BRCA, germline BRCA, and what we test when we test. Following that, we will just have a discussion over what testing methods are applicable in India, what we are doing in other countries, where we see the utility of these tests. And then tests are always one thing. How do you actually use those tests, and what are the drugs that we'll be using? So we will try to keep it as broad as possible and see the benefits and non-benefits of using all these drugs. And I would be happy to take any questions. If questions come, we can share them in this chat, and I will be addressing them over time as we go along. So what I would be talking about is HRD as a predictive biomarker in precision oncology. I will restrict myself to ovarian cancer today because that's the area where it is most commonly used. So these are all our expert panelists who have already been introduced. So what is homologous recombination deficiency? At its simplest, we have to understand that there is a DNA which gets damaged. There is an ability of the body to repair this DNA. That repair can be done by homologous repair or non-homologous repair. Essentially, if you have one strand DNA breaking, then as per the other strand, this strand will get repaired. That is known as homologous repair. So wherever there's a homologous recombination deficiency, that's HRD. Basically, what it means is this recombination is not allowed to happen. You are not able to repair the DNA. That's what it basically stands for. So homologous repair is when both the strands will again merge together, the broken or the damaged strand with the repaired strand, and then it matches with the original strand. That's a homologous repair. Whenever you cannot do that, it's known as homologous recombination deficiency. How is this happening? The commonest genes which are there are the BRCA1 and 2, the BRCA1, BRCA2, which again, we have been aware of for the last close to 30, 40 years. We know that when BRCA is damaged, it leads to a process of HRD, which leads to inability to repair the DNA. Once the DNA cannot be repaired, your genome becomes unstable. So genomic instability. And then once the genome is unstable, that causes mutations, and those mutations result in a cancer. Now, that's as at the basic level. So over time, we realize that it's just not the BRCA1 and the 2 which are responsible. You also have certain changes which are called epigenetic. So the DNA is normal, but there is a change in the DNA expression, and that is the promoter methylation that happens. That also causes the same thing. So you have the same HRD happening here. Next, you have other HR gene mutations. So there's a whole bunch of 10, 15 genes. You have ATM, you have PALB, you have CHEK2, you have RAD51. So a whole bunch of those genes, which again will lead to homologous repair deficiency status. And then a lot of them are still unidentified. However, even if the specific mutation is unidentified, you do get in this resulting HRD status, which will cause the same thing. So there is genomic instability. That's the basics, okay? So then, when you look at the components, you have something called a tumor BRCA, which is the easiest for all of us to understand. There is one gene, one more gene, both of them have mutations, and those cause the HRD. That's the simplest way to understand. Then you have this entire bunch of things known as genomic instability. So what is genomic instability? Number one, you have something called a loss of heterozygosity. So in one allele, only one allele is present, the other allele is lost. You have something called telomeric allelic imbalances. So the telomere is the last part of the chromosome that gets lost. So that again leads to more and more instability. The division is not done properly. And then you have something called a large scale transition. So you have abnormal areas, normal areas, instead of just coming from normal and normal, all these abnormal areas inside. So all these things put together contribute to something called a genomic instability, which is expressed as a score. Now, this whole thing was started by Myriad My Choice some time back. And after that, we have had many labs and many other places which are measuring this genomic instability. And that is again part of your HRD. So when I say HRD, I mean both of these. You have tumor BRCA, you have the measurement of the genomic instability. Now, this is what it is in a nutshell. You have the biology and you have its clinical effects. And this biology assessment, right? So you have what is called as a HRD, that stands for HR homologous recombination deficiency. It can be caused by and may lead to a HRR pathway defect. Now, the HRR pathway is the BRCA1, BRCA2, and all those other genes that I just spoke about. Or it could be due to a genomic instability, which means the whole genome is unstable. Both of these, so genomic instability will lead to HRD. HRD will promote further genomic instability. So that's the biology. All three of them will predict response to therapy. Now, why do those cancers which are homologous deficient respond to platinum? Because platinum forms crosslinks between DNA. Already the DNA is damaged. It is not able to be repaired because of your HRD. Then you form DNA adducts and further damage the DNA. Therefore, it gets damaged. PARP inhibitors follow synthetic lethality. So already your HRD is damaged. It's there. You do not have a repair mechanism. PARP goes and binds to the other enzyme that causes recombination and causes DNA prolongation. So that when it gets affected, both the pathways are lost. So it's a synthetic lethality. That's the clinical benefit. So if you can detect one of these three, you will find that your cancers will possibly respond to platinum-based therapy or PARP inhibitors. So then comes the question, how do you check for it? So HRR pathway defect, reasonably simpler because we know it is caused by genetic events or epigenetic. So test for those genes, BRCA1, BRCA2, test for the other HRR genes. What about HRD overall, a functional assessment? You can use some type of a functional assessment as an assay, or you could check the whole genomic instability by doing a scoring. Now, these are all the genomic scorings which are looked for. So the GIS score, that includes all the three things I told you before, or a LOH. So the confusion comes in all our minds when we get into this alphabet soup of multiple names and multiple different things. So somebody will say it's HRD, somebody calls it HRP, some calls it HR only. So this alphabet soup is what we need to get out of. Essentially, you're looking at HR pathway defects and you're looking at the GIS. These are the two things that you look for. As of today, what are approved? So I focused on the ovarian. In ovarian, you can look at tumor BRCA, you can look at the germline only BRCA, or you look at the HRD. These are the three things approved for ovarian cancer. In contrast, look at breast cancer. As of now, the data is there only for germline BRCA. People are there who are doing somatic BRCA, people are doing HRR, HRD. Remember, all these are not yet approved for breast cancer. Prostate cancer. Now, here you have some data on the tumor HRR panel, good, bad, ugly, whatever it is. You have the tumor BRCA1, BRCA2, and you have the germline BRCA. Pancreatic, as of now, only germline BRCA. So once again, there is a lot of confusion. You can do germline only BRCA, germline HRR, which is there with those 15 genes, or you can do tumor BRCA, that is a somatic gene mutation, or looking at tumor HRR, or everything put together, that is a HRD. Now, where you want to use what depends on what you're looking for. This is essentially your entire testing paradigm. So differences, germline BRCA would identify germline mutations. It is recommended for those with family history. Patients, even if they have negative germline, you still have HRD or somatic BRCA and they'll be eligible for PARP. That is something we need to remember. There are certain individual test criteria which will determine what is a better test or not. So again, not getting into way too much detail, right? So this is the way the HRD scoring is usually done. You have pathogenic variants, likely pathogenic, the different type-wise classification. Then you have the GSS score. So the GSS score, again, these cutoffs are different depending upon the labs. So Myriad could use 42, the Strand lab uses 50, somebody else uses again 42. So it's all different. You could have a GSS positive, tumor BRCA positive, or GSS positive with tumor BRCA negative, in which both cases you will still call it a HRD positive. When both are negative, tumor BRCA as well as GSS, you call it HRD negative. So let me bring in my panel at this point and start discussing about where we test and how we go ahead with the testing. So welcome to all the panelists. So let's go with a case. This is a case, is a very standard case. You have 48-year-old lady, no comorbids, no family history, presented with abdominal pain and satiety, CT abdomen, right adnexal mass, small tumor, no ascites, not very high CA-125. So you go in and operate, and unfortunately on table you find that there are multiple peritoneal omental nodules. You do a peritoneal washing, that is positive. You do a CRS, complete resection. So 3B, or it will be 3B or a 3C. That's the case that we have. So let me just start off directly with one by one all the panelists. Let me start with Dr. Chandrakanth. Chandrakanth, in this situation, you have a patient with a 3B or a 3C ovary. What would you be testing?
Thank you, Dr. Vamshi. That was a wonderful revision in the last 2 minutes. And I would thank Strand for having me. When a patient, if cost is not a constraint, in the first line, I would do HRD testing in all patients.
HRD. So you would want to do the full HRD testing, looking at the genomic scarring score. Excellent. Dr. Shona, madam, again, same question. Let's keep the costing issues aside. I mean, for the moment, at least, let's talk of what we would do scientifically. Dr. Shona, madam, your thoughts, what would you like to do? So again, I would kind of ask you to also consider the other thing. You know, you can do a germline BRCA, you could do a somatic BRCA, you could do HRD, you could do a sequential testing. In which case, you do a germline BRCA, you say that, okay, if it is negative, then I will do a HRD. Or you could ask your lab to do a reflex testing, where they test for germline or a somatic and then say that we'll do the HRD. Your thoughts on this?
Honestly, I know clinically she's a young lady. She has an advanced stage disease. She does need some sort of maintenance therapy. That's very, very clear. So we have to have a choice whether we're going to do BEV, whether we're going to do a PARP inhibitor, or we're going to do both. So I'll tell you what I do in my practice. I do a reflex testing. I start off with a germline BRCA, and then I go to somatic or HRD. So this is what I actually do.
Fantastic. This is what I was looking for, because a lot of us need to understand that it's good to do a HRD upfront, but it's not wrong possibly to do a reflex. Personally, I prefer doing a HRD. I am with the Chandrakanth school of thought. I think we were fast people. We want quick results overall together. So that's possibly why we are doing. But this is exactly one of the modifications that we could do if we wanted to. So let me bring in all the international speakers now. Dr. Sudip, sir, your plan for such cases, do you routinely do HRD for those patients who would be able to get it? What's the availability of all these tests in your country?
Thank you for the question. So, like, since it's a high-grade serious type, and though the indication is HRD testing, but unfortunately in Nepal, the access to HRD is not so easy. So what we are doing presently is doing the sequential testing. So doing the germ cell followed by if negative, then somatic. Because we are not doing reflex testing, because this reflex testing is supposed to miss nearly 5% of the test this positivity. So that's what we are doing. And regarding again the going for BRCA testing again, since we don't have access to the easy access to the individual this hotspot test for BRCA, so we are doing HRD test, which is almost same because being a single gene or in panel. So we are doing HRD for
okay,
this kind of cases. Yeah.
Okay, fantastic. We'll get back to HRD because there's something we need to discuss when you come to ovarian in that.
Yeah,
excellent.
exactly.
Yeah, excellent. So that is again very interesting to see what other people are doing. Dr. Abdul Rahman, what do you do in Sharjah? Dr. Abdul?
I think he's muted.
Can you hear me right now? Can you hear me now?
Yeah, we can hear you now.
Yes. Actually, I'm in Dubai right now, not in Sharjah anymore.
Oh, okay. Oh, you're
no
Dubai.
problem.
I'm so sorry. They have given you.
No worry about it.
Oh, I'm so sorry.
No problem.
It was written wrongly.
So my suggestion is that I don't go with reflex studies. The reason is that there's some data to suggest that if you do it after, let's say you do the BRCA mutation and trying to be positive or negative, and then you do the HRD, you might lose some results. You might have a lower the detection results with the HRD. So this is data that was suggested. So from my point of view, actually, I tried from the beginning to go for germline as well as somatic BRCA with the HRD. The key point is that as you did this patient, she's young, she deserves to have a maintenance therapy, but you did directly upfront surgery. So with upfront surgery, you have a high likelihood to have a good tissue. And whenever you have a tissue sample with about 40% tumor cells, so you have this tissue having tumor cells as well, normal tissue cells. So you can, with such as now with the new technologies, you can detect as well as the germ cell, as well as the somatic BRCA with HRD. So this would be my suggestion, not to wait and do the reflex and wait later on. We have the time, but we do not want to lose this this small margin of 10 to 15% of low HRD findings in this population. So that would be my suggestion.
Fantastic. Excellent. So just as a matter of interest, I guess in Dubai, you would have access to all of these, because Dr. Sudip was talking about access slightly being tougher in Nepal. So how is it for you?
If we remove the issue of cost and accessibility, that would be the best scenario. But we know that with the technology improving, the costs are increasing, but we are able to do all these tests here.
Okay. So you have access to the tests in Dubai, but cost is still an issue. I think that's something.
It's always an issue. It's always an issue. It's not insurance covered. So it's always an issue. But in the best scenarios, it's always done.
Oh, it's nice to know that you share the same problem that we in India have of costs, because that is something we always have a problem with. We know that the test is available, but we're not able to sell it. So Dr. Maksud, asking you the same question, what would you do in your practice again, we all understand cost, but what would you do in your practice, and what's your access to all these tests in Uzbekistan?
It's BRCA, germline, and the somatic BRCA is available here. We can do that, and HRD also we can do that. But in this case, I just recommend that to do a little wider panel of the NGS, not only the BRCA, HRD, because the patient is very young. And if you do a little wider NGS, there will be much more choice for us, and much more information for the about the tumor. It's BRCA and germline, and the somatic BRCA and HRD available, and I will do that. I will be. I should do that. Thank you.
Okay, excellent. So if I could ask you, what test are you having for the HRD? Is it the same Myriad, or is it some test developed in Uzbekistan?
You mean that it's
which company is doing it? Which company is doing a HRD testing for you?
HRD testing, here's the government company. It's free of charge. And then which company, I don't know by the name, but and the private ones also, 1-2 companies. They are doing like a small genes they are doing, but the white NGS there is no here in Uzbekistan yet.
Okay, great. So that's just, again, it's very fascinating to see across countries there is some challenges. Each one has a different test available. Some do different tests. But I think the best quote is from Dr. Abdul that, cost is an issue everywhere. So in India, we do have a few labs which are offering HRD. We do have access to the Myriad if we want, though it is pretty expensive. We need to get it done at the US rate, which is, well, let's face it, it's quite expensive. So the other thing is, somebody has asked in the quote, which is a very valid question, what is your opinion on BRCA promoter methylation? So anybody would like to take that question, Dr. Shona or Dr. Chandrakanth? BRCA promoter methylation. Do you do that testing routinely? Do you want to do it, Chandrakanth?
Yeah, so at times we have a HRD positivity, but BRCA negative on germline, So on those occasions, to find out the reason for HRD, on those instances only we do BRCA methylation. Otherwise, usually no.
Usually no. I think the percentage wise would be less than 2 to 3% if you already have a HRD that possibly covers a lot of it. Dr. Shona, madam, your thoughts on this BRCA promoter methylation? Would you want to do it in every case?
No, I don't think it's adding anything. The information I want to know is that if HRD exists or not. So I really am not keen on it.
Perfect. So I hope that answers the question. We have answered it live. Somebody has asked it on this thing. Excellent. So next is, what are the practical issues of access? We have all talked about. What about the turnaround time? In India, it's around 15 to 20 days. Dr. Abdul, what's your turnaround time for this?
Well, actually, a bit more because it's always the test is done outside UAE. Okay. So you have to count the days of shipment, but usually 14 days to 20 days is a maximum.
20 days, okay. Same
duration, we get the results. Yes.
Excellent. So again, this is a problem, I think, more unique to India rather than any other place. Because as Dr. Maksud was saying, there are a couple of labs only. We have around a profusion of labs, all of whom will come up suddenly one day and say, this test is better, we are doing already what somebody else is doing. Dr. Shona, madam, again, how do we decide as clinicians which lab to use, or where do we know that the reports are accurate enough? How do we take a call?
This is a very, very tough situation, because I think labs are coming up like shops all around India, and I think we have more labs visiting us now than medical reps. So it's tough, but you need to look at how long they've been around. You need to look at what kind of access they have to bioinformatics. What are their publications like? What are their validation procedures like? Who are the scientists working there, and do they interact properly with you? So there are a number of things that you look at. And you also, I think, as oncologists, we learn through trial and error. We do try out labs. We then, have to talk to a molecular oncologist. Some of us do have access to figure out how important that mutation really is and whether it's going to be actionable at all. So, I mean, that's the way I've gone, and I've zeroed in about three or four labs in India, which I use regularly.
Fantastic.
And so far it's not let me down. So
excellent. I think this is the lesson to anybody hearing. Anyone comes and tells you are doing it, just don't trust them immediately on face value. I think that at least in India, one thing I do ask is, are you doing it yourself? Are you outsourcing it? So there are these labs which act as an outsourcing agent. They will actually send it back to the original lab which is doing it and get you the result on a different paper. Talk to them. And like Madam says, you just have a discussion with the scientists behind the meeting. You'll understand what they're doing. If somebody comes and says, we don't have scientists who are actually interpreting it, I think that's a huge red flag which will tell us that there's a problem. We would love to have data that is discussed and published that also adds to the benefit. So these are very small things, but these are important things. And that the message which I want to give is make sure that the lab you are following is an accredited one with a good lab. Just don't trust anybody who comes and says we are doing the test, because again, the results matter a lot. So a couple of questions have come in on the audience. Somebody who's anonymous wants to know, would you like to do a BRCA MLPA when it is negative by PCR before you do the HRD? I'll just take this answer. The benefit of MLPA is more in the germline. You would do it if you're really suspecting a germline mutation in a young patient who has multiple cancers or who has a breast and ovarian, something like that. And again, typically, at least most of the labs in India do it now as a kind of reflex. If your BRCA is negative, they will immediately do a MLPA along with it. So you don't have to necessarily order it extra. So that's one thing. Dr. Firoz wants to know how critical is this to do a combined germline and somatic alterations for HRD testing. So I'm assuming you're talking of BRCA. So that's what we have just covered, that if you're doing the HRD score as a whole, it generally gives you all the information. You don't need to do germline and somatic separately in that case if you're ordering for a HRD testing. So that's, I think, answer. Anybody else would have any other comments on this?
So I think if
You made it accurate.
if your VAF is reasonably high and you're suspecting a germline from your HRD test, it would be in the interest for the family to confirm with germline testing. That's all I have to add.
Agreed. Again, you would like to know, make sure it's a germline. If you get a report on HRD as BRCA, you would also want to do a blood test to confirm the germline. Absolutely. Great. So we have covered this. So this patient after surgery, the CA125 is still a bit raised. Now a germline testing was done, which showed a BRCA1 VUS. Okay, so this is a common challenge. We get a VUS. So what would we like to do? Before that, if it's a VUS in BRCA, what next do we normally do? Chandrakanth, would you want to, like ma'am was saying, a suspicious patient, would you still like to repeat a HRD on this, or you're satisfied with this report?
Yeah, we don't know whether it is significant or not. I cannot treat this VUS because it is VUS right now. So I would do a HRD for this patient. Whether it is causing an effect, whether this patient is eligible for PAR, I will understand from a HRD.
HRD, excellent. Dr. Sudip sir, your thoughts on this? Because we do get these reports which say that.
Yeah, definitely, it's a quite common one, and definitely it puts on in the trouble. And but whenever there is a case, I usually, in case of dominant mutations, so we are a little bit cautious because the PVS which hasn't been classified as pathogenic could be pathogenic for that family. So I make sure that this has been recorded and try to go for post genetic counseling. And if patients are interested, we try to do the family the test, which is if the patients, the family have the BRCA positive of that particular allele or mutation type, so then it is a red flag for germline mutation. For as far as the ovarian cancer, definitely we would like to do HRD to confirm to move further. But I won't take it. I don't treat on the basis of this.
Excellent. So I think that brings us to the crux of, now we have been discussing what to test and how to test. So let's come to the important issue. We are all clinicians. At the end of the day, clinician has to decide what you're going to do with the report. Sometimes it's easy for the back-end people to give us a report or just say, this is what it is. And what do you do with the report? So along with platinum therapy, would anyone want to start a bevacizumab? Would you want to give a PARP inhibitor as a maintenance? Or do we go for the combination? So let me start with Dr. Abdul Rahman. What's your general practice? Would you use bevacizumab with the platinum and add a PARP later? Or would you wait for a HRD report before taking that decision? And if it is HRD positive, what would you do?
Now she's a BRCA1 positive, right?
This case is a VUS. Let's just leave this case, but let's
VUS.
talk in general.
Okay.
Let's
If,
talk in general.
if VUS, if in general, if let's say she has, in this setting, knowing that she has a BRCA positivity is enough. No need to go for further HRD with the data that we have with the solo trial, the Paula trial also. So I think if she is, as a primary maintenance, I think no need for the HRD if we have BRCA positivity. But if BRCA is not positive, it's important to do the HRD, there's no doubt. But my practice would go with only PARP inhibitor, not with the combination.
Supposing it is not BRCA, but only HRD positive, would you still go with only a PARP inhibitor, or would you use the combination of PARP plus bevacizumab?
If she's BRCA negative, HRD positive, probably I would go with the combination.
Combination, excellent. Dr. Sudip, sir, your thoughts on this? If BRCA positive and HRD positive, would you use?
So this is for primary maintenance, right? Maintenance, right?
Yes, maintenance.
Yeah. So if is it for HRD negative?
For HRD positive, BRCA negative, and BRCA positive. Two settings I'm asking.
Okay. So yeah, if these are like HRD positive and BRCA positive, since it is ID, so probably as a maintenance, bevacizumab and PARP inhibitor.
Okay,
so Paula trial.
You would use a combination as per the Paula trial. Paula trial. Okay.
Yes.
Dr. Maksud, your thought on this? So
yes,
both the settings. So again, I've given
yeah.
you the options. Would you use only a PARP inhibitor? Would you use Bev and PARP as a combination?
Here is the HRD. First variant is HRD positive, BRCA positive.
Yes.
Yes. In this case, if HRD positive, BRCA positive, I think it's better to combine with the bevacizumab with the PARP inhibitor together.
And in the second situation?
Second situation, HRD negative.
No, HRD positive, BRCA negative.
Positive, yes. BRCA negative. Correct. And in that case, only one of them. We need to choose only one of them, or bevacizumab or PARP inhibitor. We can keep the PARP inhibitor later. And the first time, if it's a naive case, we can use the chemotherapy with platinum plus bevacizumab. I think that.
Okay. So HRD positive. HRD positive.
HRD positive and BRCA negative.
Okay. Yeah. Very good. Dr. Chandrakanth, your thoughts on this?
So yeah, if it is BRCA mutant,
yes,
you will obviously have a HRD. So there I will use PARP monotherapy.
Okay.
If it is BRCA wild and HRD positive, I will use PARP plus bevacizumab.
Okay, yeah, fine. So I'll be showing a lot of data on this, and then I'll be asking you to questioning you as to why exactly we are doing what we are doing. So Dr. Shona, madam, your thoughts on this?
So basically, I know that the HRD positive, BRCA negative group from the Paula study did show a reasonable benefit with the combination. But as long as the patient is BRCA positive and or HRD positive, I do tend to use PARP inhibitors alone.
Okay, excellent. So I'm actually in your boat, but let's go with the data that has been shown. So before that, a quick revision. We do have olaparib and rucaparib available in India. I think Nepal only rucaparib is available with olaparib. I believe olaparib and rucaparib are available in Nepal as well. In Uzbekistan, Dr. Maksud was telling me they have niraparib available. So in India, we don't have much experience of niraparib, but niraparib is available there along with olaparib, right, Dr. Maksud?
Yes, niraparib and olaparib is available here in Uzbekistan.
Perfect. And Dr. Abdul Rahman, for you, again, olaparib and rucaparib are available. Niraparib is not
No,
available.
no, niraparib available and olaparib, not ruca.
Not Ruca. So again, this is interesting because in India, most of us just conveniently ignore niraparib because it's not available to us. But for both of you, niraparib is available. This is interesting because the trials are all wildly different. Now, this is the first paper which I'm just showing. Remember the benefit of bevacizumab, again, old data, but it showed that the benefit was in stage 4 and suboptimal stage 3. You had to use bevacizumab from initiation. There's no benefit by using bevacizumab later. Therefore, if you want to use bevacizumab, one important reason is if you should know your HRD, because if it is negative, you might want to add bevacizumab right from the beginning, not at the ending. So that's point number 1. Second thing, this is what I was wanting to ask, but we'll just skip that. Now, this patient completed chemotherapy, and then at the end of the treatment, CA-125 is normal. That time HRD was done and it actually tested positive. So again, interesting to note, it is a BRCA VUS, but HRD positive. So potentially this might not be a VUS, it's actually a pathogenic variant. So let's not go there. This is what we were discussing. Where would you give bevacizumab? Where would you give olaparib? Where the combination? Where niraparib? And where rucaparib? So it's very interesting because bevacizumab data is very clear. If there is HRD or there is a BRCA1, BRCA2, it doesn't seem to work. The best benefit of bevacizumab is in the wild type. So if you have a mutation or HRD positive, bevacizumab alone doesn't seem to work. But when you look at the pivotal trials, now Solo 1 is looked at only BRCA1, BRCA2. Paulo 1 is the one which actually introduced this whole concept of HRD along with the Prima trial. Now, Prima trial, remember, was for all comers. It did not look at HRD or non-HRD. And in all patients, it showed a benefit. HRD, the benefit was much more. Same thing for Paulo. The benefit was actually driven by the HRD positive subgroup, though the total subgroup also showed a benefit. So this is the data that we have. Veliparib, luckily, none of us have, so we don't need to talk about it. Now, in Paulo trial study, HRD negative and BRCA negative, both the places, it doesn't seem to work really as well. You have HR of 1 for the HRD negative, in BRCA negative, just about negative, HRD positive, BRCA positive, and this third group. All 3 places it works well. When you look at Prima, again, look at what the HRD negative subgroup is doing. 0.68, it still is positive. For the HRD positive, it's very good. For HRD negative, still seems to work. Olaparib, we just don't know what it does in a HRD negative or positive group, because Solo 1 used only BRCA mutations positive. So logically it should work, but it is not there. So this is the BRCA Paulo 1 data that I was showing. Again, everyone is interested with this Paulo data, but if you have HRD negative, this doesn't seem to work. The curves are almost the same. So the benefit of using in a HRD negative the combination, I really don't know. Whereas in a HRD positive or a BRCA mutant, the addition of bevacizumab, again, I don't know what is the benefit. So this whole Paulo combination is one which I find very hard to decipher and place in context. So let me just come one by one to all the panelists. I'll start with Dr. Shona, madam, because she agreed with me to begin with. So madam, what's your thought on this data that I have shown you?
So I'll tell you how. I'll illustrate it by a case I treated recently. So I have a young lady and she came in with stage 4 disease with a positive pleural effusion and subdiaphragmatic disease. And I gave her neoadjuvant chemotherapy with BEV. I then continued the BEV after the surgery, sent off her BRCA testing, and she came BRCA positive. Then she looks at me and says, listen, I had stage 4 disease. So I've read the data and I'm reluctant to stop the bevacizumab. I mean, very intelligent lady. So we've decided to go with the Paula study in the adjuvant setting to give her the best benefit. So this is the kind of patient who very high risk, suboptimal, stage 4 disease, where I would consider adding BEV to the PARP inhibitor.
Agreed. This is an area where, but if you leave alone such patients, where this brings us back to again the same question: should you test for the HRD at baseline? So if you had the HRD data at baseline that was HRD negative, would you do the same thing? Would you give a combination of olaparib and BEV there, or would you just give BEV?
No, I would just give BEV. if she was HRD negative. This patient I talked about was turned
It's
out to
HRD
be
positive.
BRCA
Yeah, no,
positive.
I understand. Agreed with
Yeah.
you. So, Dr. Sudip, sir, your thoughts on all this data that I presented. Somehow the HRD negative, the only drugs which work are niraparib, and then you have the Athena mono data. Again, I have tried to show you the Athena mono data separately. I'm not sure if I kept it. No, I have not kept that Athena mono data. So mono data also actually did not show great advantage in the HRD negative subgroup. The benefit of rucaparib is driven by your HRD and BRCA. So if you have a HRD negative, would you use rucaparib or niraparib? Because both have been approved in the first line.
Yeah, definitely niraparib if available.
Niraparib if
Not
available.
rucaparib.
Or rucaparib. Okay. Dr. Maksud, your practice, how would you go with it? So if it's a HRD BRCA, you said you would be okay to use the combination if it is HRD positive. But the benefit, remember the Paolo one doesn't have a third arm. It has only olaparib plus bev versus bevacizumab. There should have been a third arm of olaparib alone to know whether they had benefit or not.
Yeah, we need to assess the common condition of the patient also, but by the molecular tests, it's better. I think only niraparib monotherapy. I think in positive cases, in the first to start is niraparib is enough. I think
Excellent.
so.
I think that is why I said you are lucky in a way. You have niraparib. You can simply say give niraparib. It doesn't matter for everybody else.
Yeah.
Dr. Abdul, your thoughts on this?
Well, actually, with the tests that were used in the both trials are different.
Correct.
We have to understand that in the Athena mono, they used different tests than the Myriad. So they could have missed some HRD positive disease. That's the first thing. The second, I would use niraparib. It's a single dose per day versus rucaparib twice daily. Though the hazard ratio for rucaparib is just slightly better than the one of niraparib, very little difference. But I would go for niraparib if I have both options.
Chandrakanth, your thoughts on this?
Any PARP inhibitor is okay in a HRD positive, BRCA positive.
Okay.
If it is HRD positive, BRCA negative, I would still use VEGF. So now just wanted to put one line on Athena mono, HRD negative, there is a benefit. The probable reason which this is there is because HRD in Athena mono is not equal to HRD in Pavlo 1 because Athena mono had a less stringent way of looking into HRD. It used foundation.
That's exactly what Dr. Abdul was talking about. That they did not use Myriad, they used the other.
It did miss out some HRD positives. So probably that is the reason.
So in India, we don't use either Myriad or foundation in most cases. So you're still comfortable with giving rucaparib because, once you open that can of worms, that means every patient of yours can go on rucaparib maintenance in first line. That's a huge population when you start talking about. This is exactly what someone has asked in the question as well. That if someone is HRD negative, would you still give PARP inhibitor? 50-year-old lady, high-grade serous ovarian with multiple mets, BRCA negative, and I'm assuming HRD negative. So, this is the question that comes to you. Would you still be comfortable giving rucaparib, or you'll hedge your bets and say, okay, this is where I use the Paolo combination and give both?
See, I think what matters is what kind of PFS benefit is clinically relevant to you. If it's just 3 to 4 months that you're getting, if it's 6 to 12 months, if it's 12 months plus, I think you're going to get the most out of your PARP inhibitor in a BRCA positive and secondly in an HRD positive patient. And you want the best for your patient in that group.
Yeah, I think that's where all of us are. That Paolo 1 design has really confused and muddied the whole issue. Niraparib at least seems to be working in all cases. That's where it is. So Dr. Akhil has joined us, I think. Dr. Akhil, you put a very pertinent point in the chat, so I will let you address that issue.
Yeah. So the various analysis, including TMH meta-analysis, have clearly pointed out that HRD negative patients do not get significant clinical benefit. In our experience as well as Shona, I'm just highlighted, if the benefit is around 2 to 3 months only, the cost of the treatment and the toxicities of treatment, are we justifying that is very important. So the quantum of benefit is very different. Each of us clearly understand the same. The quantum of benefit is too low for with HRD negative, BRCA negative patients. So presently, we do not use PARP inhibitors in this scenario. So that is what I think.
Excellent. So actually,
Everything is based on everything
go
is
ahead.
based on the quantum of benefit and toxicities.
Excellent. So I think this I have not put this. I did not put the TMH meta-analysis in this presentation, but that was a very interesting IPD analysis which was done, which again showed, like Dr. Akhil says, that the benefit was actually driven by the by the HRD positive or the BRCA positive, not really in the HRD negative. So again, if you are in a country where niraparib is freely available and you want to use it in a HRD negative, you have permission, you have the recommendation also, I would say, though the quantum of benefit is not huge. Rucaparib again has the benefit, but advantage quantum is not huge. I personally don't use it. I go with only bevacizumab, or I go with only chemotherapy. I'm happy to use bevacizumab in my second line actually. This combination olaparib bev, somehow I don't know where to fit it, because it doesn't seem to be giving me additional benefit any which ways, but that's again there. So these are the data which you saw. If you looked at HRD positive, HRD, and then you looked at different subset where the quantum of benefit was. And for the primer, this is where it is there for the HRD, these two, and for the BRCA mutant. This has not shown where it is for the BRCA negative. So the Paolo 1 HR proficient or unknown, the benefit was only this much. So the quantum of benefit is not actually much. It's only a month or so in the Paolo study. The other studies have not looked at. So that's what it is. So this patient started again with bevacizumab and olaparib. Started by somebody, and again, as ma'am said, it is not wrong to give it. So I continued the treatment and so on. So my summary of the first line would be a stage 3 and stage 4 germline BRCA. Whether you complete the surgery or not, I would be happy to use any of the PARP inhibitors, as someone said. I would use niraparib, olaparib, or rucaparib. Would I use the combination? Well, it's an option. Maybe if there is incomplete surgery, if there is stage 4 where we know Bev has some benefit, I would add it there. Bev alone, again, the benefit is doubtful alone. Maybe those patients unaffordable or who fulfill this criteria. Stage 3 and 4 HRD positive with the BRCA wild type, yes to niraparib, olaparib, and rucaparib, not formally tested, but yes, I think I'll use it. The combination, I don't know what the benefit is. So that's what the data has been so far. This is the Strand experience. This is the slide they have shared. So they found that patients who underwent testing, 59 points, around 60% were HRD positive, 8.7 were tumor BRCA, and the combination is 35.8%. Only GSS came in positive in 55%. So this is a very significantly high rate. So if I can just ask all my panelists, what is your experience with your positivity rate? Chandrakanth, 55% HRD positive. How much are you seeing in clinical practice?
I mean, too less a number to comment, but 55 looks big for me. I see around 30 to 40% positive.
30 to 40%. Okay. Dr. Maksud, in Uzbekistan, what's your positivity rate of HRD?
It's we don't do the for all the patients because it's a little expensive for patients, and the testing is another. Another thing is it can afford for patients, but during the treatment also they need to pay for drugs also a lot of money. Because the insurance is not covered by the insurance, the PARP inhibitors and other tablet forms of the oncology drugs. So it's about 50-50 for my practice, about 45-50.
45 to 50. Somewhat similar to what they're showing. Okay. Dr. Abdul Rahman, your practice, your practice or your institutional practice, how much is it positive?
When we're using the myriad, actually, we can reach about 50%, but because of the availability of the test, we're reaching about 40-45%.
Okay, great. So let me come to Dr. Shona, madam.
So again, I don't have enough patients with HRD, but clearly the data shows around half the patients. And as far as BRCA goes, I think there is a very nice multicentric study published recently from India last year, which actually showed for all comers, they didn't look at family history, age, nothing, just all comers with ovarian, and they found a 20 to 24% incidence of BRCA positivity. So that was quite interesting.
Yeah, agreed. So Akhil, I've kept you for the last because again, you as you should, you tell me your entire TMH data, and it's nice to hear at the end. You know, all of us have a handful of patients. It is nice to hear one big number at the end of it. So Akhil is still driving or he's getting down from his car? Okay, we'll catch up with Akhil after this, whenever he joins us. So then the question comes, we have only last 5 minutes. I not spent too much time into this. The second line, are we using platinum sensitivity as a surrogate? You know, 2-3 years back, this was a huge hullabaloo that you could simply say platinum sensitive patients don't need to test, give it without testing. Would you test it? And if it is positive, if not used earlier, would you still use it? So starting with Dr. Maksud, would you agree with this platinum sensitivity as a surrogate, or would you like to test and then give it?
It's difficult one.
Yeah.
Yeah. Before testing and using and just blind using, you mean?
Yeah, correct. That's exactly. So if you're platinum sensitive, there was this concept that mostly these people are anyway surrogates for platinum for PARP effectiveness. So give PARP to everybody. That's what the the push was a couple of years back. So do you subscribe to that, or would you like to test and then only use?
Yeah, I only use I only use because by the studies using without testing, and the percentage is almost half and half, and I would do the blind using.
Okay, you would do without after using only. Dr. Abdul?
Without testing.
Without testing.
It's my opinion. Yeah, without testing.
Okay.
I start, but during that time, after one or second course, by the analysis, by the oncomarkers, you can just assess everything.
Okay.
It's only my opinion.
No, that's fine. That all of us have our own opinion. We are all, like it or not, none of us do this test in real life. We are all focusing on data generated by other people. Dr. Abdul?
Well, yes. No, actually, I will start. I won't do testing, but we have to keep in consideration that if you use it in PARP inhibited maintenance, you might induce resistance to platinum.
No. Assuming not received platinum earlier, not received PARP inhibitor earlier.
Yeah, go ahead. Don't test. Go ahead and start.
Don't test and go ahead and test. Dr. Sudip?
Yeah, actually, I tried to do the test, but since we don't have access to SRD, and if we find that the patient is very, very high risk, and we discuss with the patients that possibility of 50% of high-grade serous might have SRD, and they might be benefited, and this kind of drug is available which can prevent which can increase the progression-free survival. And if they do agree, then after discussion, yes, sometimes we use it, but not in routine.
Very good. So, Dr. Chandrakanth?
So I would need a biomarker to give a PARP inhibitor. So at least a tumor BRCA or a germline BRCA.
Okay. So you would want that before giving. Dr. Shona, madam? Do you agree with platinum sensitivity as a surrogate, or you think it's overrated by now?
I think it is a little overrated. And, we all have patients coming in after 2-3 years relapsing who are platinum sensitive. And these are the patients we know in our mind are probably HRD or BRCA positive. But I always like to send the testing at some point in the timeline of ovarian cancer treatment.
Completely agree with you. That's what I would be doing. Okay, last question. Use of PARP inhibitor in third line. Quite a bit of discussion on this, Dr. Shona. Your thoughts on the third line, if not used earlier, obviously.
Again, in a BRCA positive patient or HRD positive, yes, but I think the indication for monotherapy in platinum resistant has gone out, and that's really not an option anymore.
Yeah. Even the platinum sensitive, we don't have really good data as in terms of survival. So Dr. Akhil has said non-platinum sensitive, no use. That's exactly what everyone is saying, Dr. Akhil. Non-platinum sensitive, we will not be using it. For platinum sensitive, should we give or not? Well, there is not much data on that, but that is where we are. So I think that's all that I had for discussion. I think we have answered all the questions as well. So anything from any of the panelists, or we can wind up. Any questions or any thoughts for anybody on this discussion, or else I'll hand over back to Strand. Okay, so as they say, we have either discussed everything or we have discussed nothing. That's why nobody wants to talk anything more. Over to Strand people, and over to you, Shubham.
Thank you so much, Dr. Vamshi. And thank you all once again for dedicating your valuable time and sharing your extensive experience regarding the clinical utility of HRD. And it has been really immensely enriching and a scientifically enlightening session. And I would also like to thank our audience for attending a panel discussion and being an integral part of this insightful event. So your active participation has contributed significantly to the success of our discussion, and we truly appreciate your presence. So have a great weekend, everyone. Thank you so much.
Thank you.
Thank you.
Thank you, everyone. Thank you very much.
Thank you so much, sir.